Next speaker is on the topic intravitreal fluocinolone acetonide 0.19 mg for pseudophakic diabetic macular edema, and the presenting author is Dr. Rituraj VIDEKAR.
Good afternoon, everyone. My topic today deals with intravitreal fluocinolone acetonide for resistant pseudophakic diabetic macular edema. The venue of the study was Dubai Hospital, United Arab Emirates. So it was a retrospective analysis of these patients who received intravitreal fluocinolone acetonide for resistant pseudophakic diabetic macular edema in vitrectomized and non-vitrectomized eyes with 1 year follow-up. So what we define resistant pseudophakic diabetic macular edema as patients who are not responding to 3 injections of anti-VEGF, who are responding to 1 intravitreal dexamethasone implant, because all cases had received 1 dex implant, and both vitrectomized and non-vitrectomized eyes were included. These are the exclusion criteria. These are similar to what was taken in Paladin study as well as Medisoft study. Nothing different. 22 eyes who had resistant pseudophakic diabetic macular edema were analyzed. All these cases received an intravitreal injection of fluocinolone acetonide. Pre-injection complete ophthalmic examination was conducted. Post-injection complete ophthalmic examination was conducted, which included vision, IOP, OCT, macula, was done at 4, 12, 24, 36, and 52 weeks. The parameters which were checked were central retinal thickness, intraocular pressure, average number of injections 2 years prior to IVFA and 1 year after IVFA in both vitrectomized and non-vitrectomized eyes. So this is the master chart. If you note here, there are 4 cases particularly you'll note where bilateral injection was given. These were the observation. The 11 eyes were vitrectomized, 11 of them were non-vitrectomized. I would like to draw your attention to the second second table. Here the vision pre-IVFA and post-IVFA vision, there is an improvement. The intraocular pressure is slightly high, and the central retinal thickness also shows reduction. When we do a subgroup analysis of at 4 weeks, 12 weeks, 24, 36, and 52 weeks, and look at the OCT measurements, we see that more or less the central retinal thickness is more or less maintained as stable. This is against what we see in anti-VEGF, where we see a seesaw pattern because of wearing off effect of anti-VEGF. The benefit of vision improvement was maintained throughout after receiving this injection. When we analyze further, do a subgroup analysis, we see in vitrectomized and non-vitrectomized eyes, if you note the vision improvement was noted in both of the eyes, but more so in non-vitrectomized eyes. The central retinal thickness was reduced in both of the eyes, but more so in vitrectomized eyes, whereas intraocular pressure rise was more so in non-vitrectomized eyes. The average number of injections were reduced post-IVFA. Only 1 injection was required, that is the IVFA. The intraocular pressure more than 21 mmHg was seen in 1 patient who had to undergo AGS. 3 patient requires AGM, so 3 plus 1, 4 patient had high IOP. 1 patient had vitreous hemorrhage with a retinal break. So these are demonstrative OCT scans where we see a central involving macular edema pre-IVFA, which reduced over a period of time and which was well maintained. Diabetic macular edema, as all of us know, is a most common cause of visual loss in diabetic retinopathy with a prevalence of 7.6%. 66% of individuals with DME experience limitations, and without treatment, 50% of them lose 2 lines in 2 years. First line of treatment, as all of us know, is anti-VEGF, whereas the second line of treatment is the corticosteroids. In spite of the anti-VEGF, 30 to 40% patients do show persistent edema, and these are the cases where corticosteroids can be used. IVT and anti-VEGF show faster clearance in vitrectomized eyes, whereas the dexamethasone implant in vitrectomized and non-vitrectomized eyes, it has the similar pharmacokinetics. So the research question in front of us was whether IVFA will be effective in vitrectomized as compared to non-vitrectomized eyes, and whether it will have a good effect in pseudophakic DME cases. So coming to IVFA, it is a 190 microgram sustained release implant which releases 0.2 mcg per day release of the drug. It is used in patients with chronic DME. As seen in the FAME study, Medisoft study, and Paladin study, the safety profile for IVFA is well established, and all these studies particularly concluded that it helped in improved visual outcome and reduce the treatment burden. As compared to the Paladin study, which showed the IOP rise of 10.89%, in our study it was somewhere like 18%. Probably this could have been because of our definition of a high IOP, where IOP was more than 21 mmHg was considered as having high IOP, whereas Paladin study particularly took into consideration of those patients where IOP was more than 30. So vision improvement was comparable in both vitrectomized and non-vitrectomized eyes. The reduction of central retinal thickness is more in vitrectomized as there is faster washout of VEGF along with the effect of IVF as compared to non-vitrectomized eyes. IOP increase probably was more in vitrectomized eyes because of longer retention of the steroids, and number of injections prior to IVFA in vitrectomized eyes is more due to faster washout of the drug as compared to as seen in vitrectomized eyes. Post IVFA, the requirement of injection is 1 over 1 year. This drastically reduces the treatment burden and cumulative risk of endophthalmitis. So coming to the conclusion, it helps, IVFA helps in reducing the number of intravitreal injections and maintains the central retinal thickness in eyes with pseudophakic DME. IVFA has a good response in vitrectomized as well as non-vitrectomized eyes. However, as compared to the published data, our percentage of rise of intraocular pressure was much more higher than, that is 18% versus 10.89% as mentioned in the published literature. These were my references. Thank you for your attention.
So most of these eyes are they underwent vitrectomy for diabetic TRDs or for just the vitreous hemorrhage?
No, doctor. Basically, these
or
were.
You did, or the vitrectomy was done for recalcitrant DMEs?
No. This was just vitrectomy. They might have been either for diabetic vitrectomy or even coexistent. If they had some other pathology for that, they might have gone.
Okay.
So I do agree the limitations, retrospective nature and the less number of cases are the limitations of this study.
Okay, and in one of the slides you showed that in vitrectomized eyes, the vision improved, but the improvement in CMT was lesser as compared to the non-vitrectomized eyes. So how do you prove that, like if the CMT is decreasing more, the vision should also improve in that group, right? I think I saw one of your slides.
Yes, sometimes basically vision and OCT thickness might not match. So that might be one of the reasons.
So any subgroup analysis or something you try to look at why that happened?
No, we didn't do it. It would be nice to look into it. Yeah.
Thank you.
Thank you.